Good morning, everybody. You're very welcome. This is C3 Collaborating for Health's International Breakfast Seminar. It is breakfast this time. And we'll wait a few minutes before inviting Professor Prabhakaran to speak. We'll let a few more people join us. Good morning and welcome to C3 Collaborating for Health's International Seminar. Good morning, good afternoon, good evening. I'm speaking to you from C3's new office on the campus of the Royal College of Physicians, the edge of Regent's Park in London, where the leaves are beginning to turn golden, brown and red and look very beautiful. And we still have mild weather. Professor Prabhakaran will be speaking from a very different climate, but what's really interesting this morning, I think, is learning about cardiovascular issues from the second most populous country in the world. Cardiovascular diseases are still the leading cause of death globally, taking an estimated 18 million lives each year. And 1/3 of those deaths occur prematurely in people under 70. So I always think that we can learn so much from a country like India, which is why I'm really pleased to hear Dr. Prabhakaran this morning. We've, in the UK, just had one of, I guess, several reports published into the handling of the COVID-19 epidemic here. And one of the key messages is that we don't do enough about learning from other countries. And we at C3, whose mission is about preventing chronic disease, try to bring to you, and we will this morning, people from other countries with interesting messages and lessons for us. So I'm really delighted that Dr. Prabhakaran, who I've known for many years, has the time this morning to speak to us about some of the exciting ideas coming from his work in India. Prabhakaran, over to you.
Right. Thank you very much. And good morning to everyone. And I'm delighted to be participating in this meeting. And I'm delighted some of our old friends are here to listen to my talk. Can I share my slides, please? I mean, you have to stop sharing your screen, right?
So please put comments and questions in the chat, and I know that we'll have time at the end for some discussion, but put your comments and suggestions and questions as we go along. Over to you, Dr. Prabhakaran.
Right, thank you very much once again. And I will start off by saying that though it's titled as Innovations to Improve Access and Quality of Cardiovascular Care, I'm going to use hypertension as an exemplar. I mean, a lot of work has gone on in the arena of cardiovascular disease, but hypertension is a good example to start with. And I will take you through the journey of some of the innovations that we have carried out in India to combat hypertension in particular and cardiovascular diseases in general. So if you have to talk of the cardiovascular epidemic and the French Revolution, because we are in London and You're comparing to Paris and other cities. As Charles Dickens said, it's the best of times and it's the worst of times. And for cardiovascular diseases also, it's true. Essentially because tremendous achievements have happened both at the population and individual levels. There's been a population level decline of cardiovascular mortality of more than 50% in high income countries within a single generation. And there's been a decline in acute myocardial infarction or a heart attack mortality from around 30% to 4% in 50 years. There's a substantial decline in cardiovascular risk factors. And let's look at the flip side. There's uneven prevention policies across the world. There are huge disparities in care within and between countries. There's lack of simple and essential drugs in many parts of the world, and there are gaps between best practices and actual delivery. So how do we reduce the gaps in cardiovascular disease care? So one is we require a committed, comprehensive cardiovascular or chronic disease prevention program. We also need to address multiple challenges that come along the way, including the lack of good surveillance system, lack of attention to upstream determinants, particularly in the arena of policy. There are several areas which can actually combat, are useful in combating cardiovascular diseases. We need to understand new mechanisms, understand the mechanisms of disease, because ethnicities differ in terms, though we say that the risk factors are very similar, the thresholds at which they operate, the kind of clustering of risk factors and the comorbidities that we see are different across ethnicities, and we need to understand the mechanisms as to how they happen, be it genetic, biological, or even health system oriented. So you need to look at the mechanisms. There's need for disruptive innovations to improve CVD care and strengthening primary care, because primary care is the pivot in addressing the burden of chronic diseases across the world. Building a cadre of independent researchers and actually building capacity of primary healthcare workers as well as primary care physicians is important in the prevention of cardiovascular diseases. Last is the focus on policymakers. We need to synthesize and disseminate information to them in a way that they can understand and they can use that in modifying their policies. Build large-scale collaborations, and all of these requires a multidisciplinary and multi-pronged approaches. There are obviously several examples across cardiovascular disease. I'm going to use hypertension as an exemplar. So there are multiple dimensions of implementation using hypertension as an example, includes opportunistic screening, scaling up and implementation of hypertension control innovation, telemedicine, the role of environmental hazards and its mitigation, and providing policy option to policymakers. And I'll discuss some of these. The reason why I am focusing on so many things is if we have to make a change at a population level, we need to address four things. As researchers, as clinicians, as physicians, we think of scientific credibility, and our research is largely focused on biomedical and epidemiological research. And we need to generate that evidence in terms of both strength, quality, and generalizability. But we also need to know and ask the question to see whether it's feasible, whether it's affordable. So in that sense, we'll have to do financial feasibility and health economics research. Once that's done, and once we know that something is cost effective, we need to implement it on a large scale. And for that, the next question is it going to be sustainable? Is it going to be scalable? And that's the operational stability aspect. And that comes from health systems research. But ultimately, whatever we may do, the community has to accept what we are proposing, and therefore we require social sciences research. So as you can see, if you put all of these together, it would be a transdisciplinary approach. And as you can see, control of chronic diseases or diseases like hypertension, diabetes, or cardiovascular disease requires multidisciplinarity. It requires some disruptive thinking, and we need to pay attention to policy and upstream determinants. Now, why did I choose hypertension? It's very simple. Whatever goals that you may want to look up, the WHO goal of 25 by 25 or the SDG goals of 30 by 30, hypertension is prominent in any of their strategies or tactics. So I thought it's better to start off with hypertension. And it also has the interventions with the best possible evidences so far. But let me talk about the irony of hypertension or high blood pressure, because it is a disease of three paradoxes. It's easy to detect, but the diagnostic rates are dismal across the world. It's easy to treat, but treatment rates are disappointing. Some parts of India and Africa, only around 10 to 20% of people who are known to have hypertension get treatment. There are several potent drugs are available, but control rates are abysmal. Even when they're treated inadequately, so that they're not treated to targets. So in terms of high blood pressure, there are two or three things which people talk about. One is an emphasis on awareness and screening program. And the question is, do they work or should they be used as a tool? So the most of the time, awareness is created by providing information. So the aspect of providing information so that people gain knowledge has gained a wider prominence than the other two, which are also important. So if in terms of behavior change, we need to look at three aspects. We need to impart knowledge so that people say, I know. We need to motivate them so that they say, I want. And we need to provide them skills. This is at the general population level, so that they say I can. And combining all of the three, they can say that they will act and perform personally and reach and teach others and say that it's possible. But we all need enabling environment for this. For example, just to give an example, we all know that fruit and vegetable consumption can decrease blood pressure. In many parts of the world, it's very difficult to access fruits and vegetables. They're very expensive. So we need to have policies in terms of increasing the fruit and vegetable consumption. Sodium reduction is a policy option, but they are rooted in strong cultural practices in two large countries, India and China. So you require to focus on the culture too. I mean, the question of processed food consumption in India is not that high, maybe in 5% or 6% of the population. What do you do to the remaining 95%? So we need to think of those kind of things. Last is about the screening. A lot of people have advocated mass screening, go to houses of people and just screen for blood pressure. But what do you do once you know that they have high blood pressure? Some of them may be false positive. Some of them may have come out of anxiety. So you'll have to repeat it again. So one of the best possible ways of doing it is to do an opportunistic screening. So in that regard, we created the May Measurement Month campaign in collaboration with Imperial College, the International Society of Hypertension and others. So it's a worldwide screening program. Currently, we have every day of the year earmarked to something or the other. So May 17th was earmarked as World Hypertension Day, and everybody was supposed to create awareness and advocate for hypertension control on that day. Professor Neil Poulter from Imperial College thought, why not do it in a month and get everybody to do it voluntarily across the world. And so there are 100 countries which participate in this program. I'm specifically giving data from India here, where there have been 50 plus participating institutes across India. We created 500 plus screening sites, and more than 20,000 healthcare professionals have been involved in the screening process. And in the last 3 years, actually last year and this year, there have been no campaign because of the COVID pandemic, but we screened close to 1 million people. The idea is not to detect hypertension, that's one of the things, but the most important thing is to create that awareness. It creates that thing that we have to do something about it. In addition, you also screen individuals with pre-diabetes where lifestyle advice is provided. In China, follow-up of these individuals has shown a mean decrease of 6 millimeters of mercury. Just by simply doing a voluntary screening, you are able to create that awareness, and providing simple advice can make a change in the blood pressure. So behavior change, as you know, is very, very difficult. And this is the story of family planning in India. In the 70s and 80s, the population grew and grew despite the effort of teaching how to use a condom. So you can see how communication can be very difficult. So in terms of high blood pressure, the next question that we wanted to ask is, what are the health system innovations that we can do? Can we do task shifting and task sharing, and can they help? And can we use digital health to address some of these issues? So the things that are involved, the reason why we thought about doing this was, one, we could link the community to the health system. We could improve access, availability, and distribution. We could address human resource shortages given the low availability of physicians across the country. And we could do quality improvement, team-based care, among others. So in terms of technology to address health disparity, what is needed, there are several things that can be done. I'm not going to get into all the details. We need simple things. I mean, these are all the, if you have a menu of options, these are all the things that are available in terms of technology for us for cardiovascular disease prevention and management. I'm going to focus on two things: the electronic decision support system that we have developed and the role of telehealth, and briefly touch upon capacity building. Uh, in terms of capacity building, you need to build capacity of primary care physicians and nurses who are reticent in terms of managing hypertension, because during the undergraduate training, I'm talking about particularly for India, where not adequate attention is given to chronic diseases. So we have created a mechanism of building capacity on a large scale across the country. So I'll stop at that about that. Due to paucity of time, I'm not going to dwell into a greater detail, but maybe address during the question and answer session. But I'm going to talk about these two aspects: the electronic decision support system and telehealth. So why do we need ML technologies? For consumers, it provides improved convenience, more active engagement in self-care, and greater personalization. For clinicians, it reduces the demands on their time and refocuses on the art of medicine. And it has a potential to change every aspect of healthcare environment to do so while delivering better outcomes at substantially lower costs. So 10 years back, this is what the situation we were in. We did not have real-world clinical trial evidence to provide a roadmap for implementation. We also did not know whether it would be low cost, whether it could be potentially scalable and sustainable, and make real differences to people. We had done a cost effectiveness analysis. Professor Tom Gaziano from Harvard, myself and some of the others, we did an economic modeling, and we said 3-day training program would reduce hospital costs by around $700,000 per million population annually. It could prevent 700 cardiovascular disease deaths per million, and 750 hospitalization for stroke and MI can be avoided per million population. And this could be cost saving if the annual salary of community health worker drops below $3,500. At that particular point of time when we did the analysis, this was around 15 years back, our community health workers in India were getting something like less than $1,000. So clearly, this could be a game changer in terms of management of hypertension, diabetes. And there are a lot of examples from HIV and other diseases where community health workers could be used. So we said that low-cost interventions can improve outcomes of people, and we wanted to pair them with pair these community health workers with and enable them with technology to improve healthcare. So the principles that we use, there were several studies that we conducted, which included trials, individual randomized trials, cluster randomized trials, demonstration projects, so on and so forth. The principles that were used was electronic decision support system for a variety of diseases, the integrated care that we talked about rather than treating each disease in a silo. Quality was an important aspect, so quality improvement programs were part of all these studies. Cardiac rehabilitation for those who had a myocardial infarction or stroke, and team-based care, particularly here is an example of team-based care in patients with diabetes and depression, where we use paired technology, simple technology like Skype, where psychiatrists, cardiologists, nurses, physiotherapists, and others would talk to each other on a given day and discuss patient management. And it showed that there was a substantial improvement in control of diabetes and depression. But as I said earlier, I'm going to focus on hypertension. So as I said earlier, we conducted this in multiple settings: community, primary, secondary, and tertiary care level. There were multiple methods that were used, which included formative research, randomized controlled trials, and randomized projects. There have been more than 20 high-impact publications in the last 10 years, and we scaled it up across 2 states in India. Now we are doing a pilot for national level scale-up. So in essence, we are trying to create a sustainable program, and we are foraying into new areas. So in the initial step, when we started, we conducted a situation analysis, generated evidence. We also looked at the health system, whether it was ready to adapt to this change. Then we did a scale up and did sustainability. So between February and September 2011, we conducted systematic reviews. We developed the software. We did beta testing and validation, and several methods such as qualitative research, end user testing, and real versus virtual comparison and comparison against experts were conducted. Here is the comparison of the software output against cardiologists' management plan. And you can see that the area under the curve was 0.84. which is kind of excellent because anything beyond 0.72 is good. You might ask about the remaining 14%, but the program was developed in such a way that there was autonomy for the physicians to modify or to agree to the treatment. And therefore, this was an excellent thing for us. And so we did a trial with primary care physicians who were the gold standard. So we did not go to community health workers at that time, but did the study in primary healthcare physicians and found that the software-based advice, if people followed the software system, they had a better control of both systolic and diastolic blood pressure. And we then thought we should extend it to community health workers and then scale it up. So we created this program called Empower Heart ML system, which is a clinical decision support system for evidence-based care. This clinical decision support, intrinsically what it does is three things. It aids task shifting. It has a training module and access to experts, and has a clinical decision support system. It provides a holistic approach for evaluation, screening, investigation, clinical management, follow-up schedule. It's based on accepted clinical guidelines for management of several diseases. The algorithms were validated by experts and proven in clinical research. There are personalized lifestyle recommendations for patients. There's inbuilt record keeping, trending and charting at patient level and practice level, and several other features for care delivery management. So this is the workflow. The patient walks into the clinic, gets referred by a health worker. And if the patient is above 30 years of age, the patient is referred to a nurse or a care coordinator who is positioned in these clinics. An initial assessment is entered into the nurses portal, which has around 22 questions. Now, just to give an example, if there is a patient who's 60-year-old male, blood pressure of 160 by 102, no diabetes, has bronchial asthma, and has other minor illnesses, comes to this nurse and she enters the data, the output that is given would be a diagnosis of stage 1 hypertension, bronchial asthma, and the advice would be to avoid beta blockers, to advise amlodipine at 1 unit dosage. Now, the reason for having this printout is peculiar to India because non-physician healthcare providers are not allowed to prescribe. So essentially, the prescription has to be provided by a physician. So the patient goes with the printout to the physician. The physician can agree or disagree to the clinical decision support system plan. And once the physician agrees, accepts the recommendations or rewrites the prescription, the patient comes back to the nurse. Now the nurse, based on the data given by the patient, can provide lifestyle advice. For example, she could focus purely on diet or physical activity or tobacco, depending on the need of the patient and the output of the decision support system. The patient walks out of this with a prescription. In addition, there's auto texting feature for follow-up so that both the nurse and the patient get the text. And if the patient does not come back, the nurse can follow up with the patient to come back for a follow-up. So this is a very simplified app. It runs both on Android and iOS. It can be integrated with any other platforms. It stores longitudinal patient data in an electronic format. We have developed decision support for hypertension, diabetes, dyslipidemia, chronic obstructive lung disease. Asthma has also been done. Now we are working on a trial on routine antenatal care, pregnancy-induced hypertension, gestational diabetes, and anemia. It also facilitates screening management, follow-up, and counseling, and provides real-time monitoring. This was a study which was conducted in Himachal Pradesh in 6 government outpatient clinics, where over a 1-year period we screened 21,000 individuals and identified nearly 6,800 of them to have either hypertension or diabetes, largely hypertension. The point that I want to make here was that 50% of these detections were first-time detections. If not for the system, they would not have been detected, because the general practice in primary healthcare is if you come with fever, you are given Tylenol or something equivalent or investigated for fever. Nobody measures blood pressure or blood sugar. So this system mandated the examination of blood sugar and blood pressure in people above the age of 30 years. So we looked at what happens to them over a period of time. And as you can see, this is for systolic blood pressure and this is for fasting blood sugar. By the second visit, the blood pressure had fallen, and it continued to fall at 6 months, and then it continued to remain stable at 18 months. Even more dramatic was the fall in blood sugar, which continued to remain stable at 18 months. There were no fancy medicines. There was nothing new really. All we did was we requested the health system to make available the simple drugs that were part of the Indian public health standards. And all that was done was to improve the systems level approach where patients came back to follow, got their medicines, and they were reminded in terms of their treatment. The doctors were provided some kind of training in terms of managing these conditions. So from there on, we actually did several trials, like for example, at tertiary care, we looked at comorbid conditions, community level care, then at the level of primary care. Then we scaled it up in 2 northeastern states, and now we are doing a national level pilot. We also assisted the WHO in converting their pen package into a digitized format, which is being used in Maldives. Now we realize that this is a very siloed approach, disease by disease approach, and we need to look at a symptom-based approach, and we need to look at comorbidities, and we are working on that. So in terms of research to policy, if I have to summarize, the development, feasibility, and proof of concept took almost 3-4 years. Then the evaluation took almost 6 years. The scale-up took another 2 years. Now we are at a national level. So this is what we did in terms of the electronic decision support system. Moving on, I'm going to talk a little bit about the role of telemedicine and why telemedicine is important in the current era. So by March 2020, there were several regulatory changes in India because of the COVID pandemic, because the policy reforms in India liberalized the use of telemedicine. Earlier, telemedicine was not very rampant because of several regulatory roadblocks. But despite this, there are several, there's a big divide between educated and less educated, between the poor and rich, because there's poor penetration acceptance of telemedicine in rural areas and subpar utilization in urban areas. So the barriers in telemedicine are threefold. One, at the patient level, there are challenges in accessing telemedicine services due to literacy, language, or technological barriers among patients. There's lack of good clinical history, physical examination findings, and laboratory parameters that aid physicians. Because the current telemedicine programs is that the patient initiates the telemedicine consult, but they can go to the wrong doctor, and they are providing the data themselves. Whereas in the mechanism that we have suggested, which is assisted telemedicine, a community health worker obtains data through several technologies that we have paid, which I'm going to talk about a little later. In terms of the multiple innovations in digital health technology, there was no interoperable system, or there were interoperable systems which were very expensive. But we created an interoperable system that puts them on a single platform. So I'm going to speak about what are the innovations that are there in this system. So this is just in brief the barriers which I spoke about and the solutions that we have planned in terms of the barriers. So literacy, language, or technological barrier amongst patients. We trained healthcare workers to connect, convey findings, and facilitate doctor-patient interaction, and also prevent wasteful visits. For the doctors, they were frustrated by lack of good clinical history and physical examination. We again trained healthcare workers to collect history, perform physical examination, carry out lab investigations before initiating teleconsultation, thereby saving time and improving quality of care. There were, to cater to the problem of interoperability, we created a system in which the several digital technologies were interoperable. So the salient features include upscaling skills of health workers in providing assisted telemedicine, improving access to primary and tertiary care through trained personnel, improving quality of care through point-of-care diagnostics and electronic clinical decision support system, reducing the need for follow-up visits to health facilities, real-time monitoring and feedback mechanism that assure quality standards. So here are the digital health technologies that we have paired on the telemedicine system. I've spoken about the Empower electronic decision support system. I'm not going to talk about it further. This is a homegrown point-of-care device, which currently conducts 11 tests, mostly focused on reproductive and child health. But to this, we are adding something called the Swasthya Pro, which will do lipid profile, hemoglobin A1C. It's a work under progress, but within the next 3 months, we will have lipid profile, hemoglobin A1C, and even possibly TROP-T and troponin T and BNP, NT-proBNP. In addition, we have an AI-enabled ECG device, which gives a quick, easy to use and works in conjunction with several Android devices. It's FDA approved. It has a cloud-based system with AI interpretation and risk classification. To give eyes and ears to the doctor, we have provided an electronic steth with which they can hear. I'll just demonstrate that in a bit. And we have a high definition camera so that the doctor who's sitting remotely can turn the image, can look at very close, zoom in and zoom out, and can do manipulations to get a better view of the patient. This is how our platform looks like. But let me tell what all it can do. It can look at general physical examination findings. It can provide it to the doctor. It can capture both presenting personal, past, family, and drug history in great detail. It can provide the vitals in a longitudinal graphical format for every visit. And it measures multiple vitals, including blood pressure, pulse, oxygen saturation, and so on. It can provide lab results with trends. It can obviously give the ECG readings. And it has the electronic decision support system, which integrates all this information to provide a personalized management plan. And finally, there is facility for e-prescription and also there is a prescription history. The doctor can go back and refer to what was given earlier because people tend to lose these things. And then there's a markup for follow-up visit and markup for referrals. This is an example of the stethoscope sound, which you can hear remotely. If you have an earphone like me, you can hear it better. But this is the heart sound at the second heart level. Then we thought one is that the patient has to come. Can the community health worker or the nurse go to the patient? So we thought of an on-foot telemedicine assistance, and you can see all the equipments that we've used in the telemedicine can come into these two small bags, and they can carry it and actually conduct doorstep telemedicine assistance. This is an actual telemedicine program which is running. And here is our health worker who's talking to this patient and getting connected to a doctor remotely. The other thing that we can do is for screening purposes, for surveillance purposes, we created a health kiosk, which can be assembled and put anywhere, be it in train and metro stations, airports, bus stations, etc. And it can be used in clusters of small villages with population of less than 5,000. And last is the digital health on wheels, where if you do not get a place to examine the patient, you can create an examination room within this van, and it can be used in small villages with population less than 5,000 or so. So these are some of the innovations in terms of telemedicine and electronic decision support system. The third point I want to make, as I told earlier, is we need to address upstream determinants. And the biggest upstream determinant now is air pollution. There are others like tobacco, and which are being tackled. Tobacco control is has been done on war footing in many countries, but air pollution, the same attention has not been given. So if you look at the environmental determinants of air pollution, of hypertension, it includes air pollution, noise pollution, lack of green spaces, water pollution with heavy metals, and several others. So we need to create and look at and see if there is an evidence in terms of these pollutants. So these are related to lead as a pollutant, and I'm not going to focus on that, but I'm going to focus a bit on air pollution because that is very topical, and you must have read about how bad it is in India in terms of air pollution, how during winter times there is PM 2.5 levels which are sky high. So this again brings us to the philosophy which was brought about by Jeffrey Rose, who said sick individuals arise from sick populations, and sick populations are created by sick societies, and therefore we need to address that. So how did we study this? We have assembled two large cohorts in the cities of Delhi and Chennai called the CARS cohort, which has 19,000 individuals who have been followed up over the last 10 years biannually with full details, and annually in terms of their admissions, mortality, and morbidities, and so on. And another program called GeoHealth, where we collected PM 2.5 levels by a unique modeling technique, which I'll talk about, for every day between the years 2010 to 2016. And then we linked it to blood pressure, diabetes, and several other chronic diseases. So how does the CARS cohort work? It's a population-based sample of around 20,000 adults followed for up to 8+ years. It's representative of the megacities in North Delhi and in North, that is the city of Delhi, and in South, the city of Chennai. It's carefully phenotyped and genotyped study population, and it has around 360,000 stored aliquots of sera, plasma, buffy-coat, and so on. So this is the flow of the study. After the baseline survey, biannually we collect blood and other data in detail, but in the interim we collect data on morbidity, hospital admissions, and so on. In terms of the GeoHealth program, the whole idea was to assess two things. One is to assess the exposure, which is the PM 2.5. That was the initial part of the study, but we are looking at other pollutants now. And then link them to cardiovascular risk factors and outcomes, and also to build capacity in the science of air pollution. So this is the city of Delhi. We divided the city of Delhi into 1,635 grids of 1 kilometer into 1 kilometer. And we calculated the PM 2.5 levels at each of these granular level, because if you use the monitors, they have a spread of something like 25 into 25, and they're very diffuse. They're not very accurate in terms of capturing the PM 2.5 levels, especially if you have to link it to a disease. So we use several sources to obtain the data. We obtained data from the 25 stations in Delhi. We also looked at the satellite data every day, because the satellite runs through Delhi twice in a day, and we obtain what is called as aerosol optical depth, which gives the PM 2.5 level, which is a marker of air pollution. We looked at the vegetation index and ultraviolet emissions and active fires. We also obtained data from the polluting industry emission inventories, which are located in around Delhi. And we obtained daily data of temperature, relative humidity, wind speed, precipitation, cloud cover, and several other aspects. Along with that, we used looked at the land use, particularly the length of roads and runways, location of bus stops, bus terminals, railway stations, and so on, because these are required to adjust to the PM 2.5 level. So this is pictorially represented here, all the data that we collected, and we used a chemical transport model and a model called ensemble modeling, which uses a machine learning algorithm adjusted for meteorological variables, and obtained data of PM 2.5 over a 7-year period. And you can see how from 2010 to 2016, the number of months which are red increases, which means that the pollution levels in Delhi increased between this 2010 to 2016. You can also note that the red actually starts in the month of October itself in 2016 and goes on till March. So clearly a very high level of pollution. Secondly, using this data, again, we looked at the walkability index, because we asked patients to walk to control blood pressure. Is there walkability in Delhi? And you can see there are very few green areas which are there in the central part of Delhi. Third was, we looked at traffic density and blood pressure level, and wherever the traffic density was high, the larger dots represent higher blood pressure, smaller dots represent lower blood pressure, lower than the mean, higher than the mean, and so on. So clearly a lot of data have been obtained, and then we connected the dots to look at what happens. So we looked at 3,296 individuals from 2,200 plus households over a 7-year period. And we used a longitudinal mixed effects model adjusting for demographic variables, risk factors, road proximity, etc. So we noted that for every 25 microgram per cubic meter increase of PM 2.5, the blood pressure was high by 3 to 5 millimeters, depending on the BMI. So we calculated that decreasing annual PM 2.5 by 25 microgram per cubic millimeter will decrease systolic blood pressure by 3 millimeters of mercury. So you might ask, what is 3 millimeters? After all, 3 millimeters is nothing really. But at the level of population, 3 millimeters is huge, as I'm going to show it to you in the next slide. We looked at the data. If you even achieve the liberal national standard that we have in Delhi, the prevalent hypertension will decrease by 15%. So it should decrease by 15%. So as you can see here, you're asking about, I was mentioning about 3 to 5 millimeters of mercury, what can it do? Even a 2 millimeter reduction in a population can reduce stroke mortality by 6%, CHD mortality by 4%, and total mortality by 3%. If you're able to achieve 5 millimeter reduction, we can reduce the stroke mortality by 14%, and CHD mortality by 9%, and the total mortality by 7%. So that's the power of population level changes. But we need to create awareness. We need to talk to doctors. We need to build their capacity. And healthcare system itself is an important contributor and also a mitigator for environmental health. So we are working on strengthening the capacity of research, communications, and advocacy on air pollutions. And we are working on several areas, particularly in terms of improving the understanding, knowledge, attitude, and practice of healthcare practitioners towards health effects of air pollution in Indian cities. And this could be used for air pollution monitoring, policy, and advocacy. The last point that I wanted to make is about policy translation. There is, how do you convey all this to policymakers? I mean, whatever I have spoken may appear to be jargon to many people, and particularly to policymakers, and they'll get bored. You will have to talk, you're given only 2 or 3 minutes and you have to talk to them because they're bombarded with a lot of information. We talk about limited knowledge, we talk about stakeholders, none of which they really understand. So in this regard, we have created documents for policymakers, particularly working with the Disease Control Priorities Group. I led the cardiovascular, respiratory, renal, endocrine disorders and published it a few years back. It takes into global evidence on effectiveness, cost effectiveness of interventions. And currently this is being piloted in Ethiopia and Pakistan. So it summarizes and synthesizes the evidence of the effectiveness and cost effectiveness of global health interventions. And it strengthens capacity for evidence-based priority setting in global health and introduce new methods for assessing the equity and financial protection considerations of health intervention and policies. I'm not talking about that in great detail here. Here is the link. The slides will be shared, so you can use this link. And this book is available freely in the through a Google search. So it has 22 chapters, and it covers early exposures, tobacco, weight, physical inactivity. In terms of cardiovascular disease, covers ischemic heart disease, stroke, and peripheral arterial disease, congenital, rheumatic, Chagas, and other heart diseases, heart failure, diabetes, and kidney disease. We also work in developed several advocacy documents, such as the World Heart Federation roadmaps, which provides cost-effective interventions to achieve the World Heart Federation goals in priority areas. It identifies potential roadblocks along the continuum of clinical care for cardiovascular diseases and also provides potential solutions. An example is given here. If you start to finish in terms of cardiovascular disease, first we want to look at if the healthcare system is accessible to patients. Are clinical guidelines recommending priority interventions available? Are the healthcare professionals able to prescribe the recommended treatment? Are the priority interventions actually available in the health system? Are they affordable? Is the healthcare system organized to ensure adequate follow-up of patients with cardiovascular disease? And do the patients adhere to the recommendation? So in effect, you require to go through all these steps to make a big change in the health system. And there can be roadblocks. So in a particular country, there can be lack of healthcare professionals to prescribe priority interventions. So in which case you could shift some of the roles. You could do a sharp task shifting as we demonstrated. Priority interventions may not be affordable. So one could promote the use of good quality generic medicines, promote local manufacturing, bulk purchasing or pooled procurement and so on, and provide financial and social support. So these are some of the solutions that we have. So clearly these are 3 advocacy pieces which have come out in the last 6 months or so. I just put it out so that if you want to have a detailed look, you can have a look at this. So to summarize, research to policy is a continuum, and the pathway consists of research. You need to synthesize the evidence, disseminate the evidence, act on that evidence, scale it up, and create a sustainable policy. So to make research effective, we have to identify what are the critical gaps in knowledge. We have to influence policy change that are informed by evidence from research, design and evaluate health programs for greater impact, and engage other stakeholders in the society. To summarize, good quality research and high impact publication is not at the end of the world. It should be widely implemented, and policymakers need to be provided evidence in a manner that's attractive to them. So as you can see, technologies are reductionist, but solutions have to be holistic. And these are my collaborators. So I would thank them in French, but in English, I would ask for mercy if I left anyone out. And this is my family who was supported in my journey, and this is my extended family. So thank you very much.
And a big thank you to you. The scale and the length of time of the studies you've talked about are breathtaking and really very significant. we've a couple of comments, questions already on the chat. I wonder, Alistair Fisher, would you like to unmute and ask Dr. Prabhakaran your question?
Yes, I'm just wondering where I can find my question. I'll go to it. Yes, I've always found that it's very hard to visualize what blood pressure entails. In other words, how does it work? How do you convince members of the population that you are carrying out scientific treatment rather than waving a magic wand?
Great question.
This is one of the toughest questions that has ever been asked to me, and I'm a little stumped as to how to answer this because it's been difficult. We did an empirical study, which I have not presented. I took out the slide because of the number of slides that I had, where we screened 100,000 individuals, identified whether they had hypertension, diabetes, or an absolute risk, because the current concept is we have to manage people with absolute risk. That is based on their levels of, because the current paradigm of thinking is it's not dichotomous that people have hypertension and no hypertension, but it's a continuous risk. So the risk is a continuum. If the blood pressure is elevated a little bit, if the blood sugar is elevated a little bit, and they have a few other risk factors, in combination, it's much worse than having high blood pressure. So we did that screening. So, it was not a big surprise to us. People with diabetes went to a doctor when they were referred. They went to the clinic, got the treatment. Nearly 50% of them again. Hypertension, nearly a third went, and very few with those with absolute risk actually went to a doctor. To answer your question, it's very difficult to convince people that they have hypertension because they are asymptomatic. So we have to actually improve our communication in terms of what to do about it. The other problem, biggest challenge now we are facing in India is the WhatsApp messages that come saying that this is all a conspiracy by the pharma companies in terms of increasing treatment. So we have to combat by saying that it's not at all expensive. It is free of cost. It's available with the health system and it's provided free of cost. So people have to try and use that. But I would like to hear I'll pass the question to you and ask you, how would you say that this is not mumbo jumbo, but this is actually a scientific thinking and it improves your treatment? We have tried, I think basically as physicians, maybe we are poor communicators, but I would like to ask you what you would do.
What I would do? Well, I'm
Okay.
I'm an economist. I'm not a clinician, but as I understand it, it has something to do with the elasticity or otherwise of the arteries, and therefore it. And I would think that if you, I don't know, there was nothing in your talk. About the only thing that wasn't in your talk, by the way, because it was such a wonderful tour de force. But one thing that wasn't in it was anything to say, how do you describe blood pressure to people who don't know just those simple facts?
Right. So I didn't understand the question. Sorry, I didn't understand the question. That we have patient educational material in which we, in very simple language, explain what is blood pressure and how does blood pressure affect the various organs. The explanation that you gave is very simple, and we use something very simple like that. That as you grow older, there is increased stiffness of the arteries, and the heart requires more effort to pump blood to various parts of the body. So there are two numbers. The upper number is related to the pumping of the heart, and the lower number is related to how much the blood vessel can relax. That's what blood pressure is. So there are various ways of explaining. Yeah.
So can I invite Michaela Nuttall to almost continue that discussion and comment, I think. Michaela, can you unmute yourself?
Absolutely, thank you. And thank you for an amazing, inspiring session this morning. What a perfect way to start Tuesday. I'm, as Christine has just said, Michaela Nuttall. I'm a nursing associate here at C3, and I have a couple of other roles as well. And hypertension is Well, it's one of my babies, I have to say, and not just hypertension. I'm really interested in the education and training of not just patients or people, but also healthcare professionals and anybody that wants to know about hypertension. So, Alistair, I'll happily sort of give you a little quick update on hypertension in really simple ways. And that's one of the things I find, whether it's for healthcare professionals or for patients, breaking it down into really simple, easy to understand steps really helps people to understand it and allows healthcare professionals to talk to patients in a way that everybody gets it. But I wanted to share something. I had put a question on there about the decision-making tool, because we've been working on a project called Share the Pressure. And this was where we worked with healthcare professionals and patients to try and get a way to get patients to understand the impact of their blood pressure, not just telling them the numbers, but what impact that might have. And we've been able to use the CVD risk algorithm and put it into patients with hypertension and give them their heart age. So whilst people may say, well, this is my blood pressure, it's not that bad, it's okay, this is in my family, everybody's got high blood pressure. But when we start to explain, well, you're 52 and your heart age is 62, and actually you can reduce your heart age by reducing your blood pressure by taking more exercise, we've found that to be really useful. And that's something I'd really happily share with everybody that's there. Going on, I'm sorry, I'm doing a monologue, not a question.
You're going on, but you're also crackling. So I might pass on to Glenn Stewart to ask his question next. Glenn, are you there?
Hi, thanks very much. I was just interested in what you think it comprises when you're sort of talking about CHD or cardiovascular disease and air pollution. I mean, there does seem to be sort of several answers there, but also if you sort of widen it to NDCs as a whole, I'd be interested to understand what you think of as a health system and how the health system could be used to prevent all NDCs. Because I mean, everyone on this call, I think, will know there's a sort of link between, well, there can be very sort of useful links between reducing air pollution and increasing physical activity, or I know increasing better diet, or reducing or what we call LTCs over here as a whole. So instead of trying to sort of go down the route of treating one disease, how do we reduce NDCs as a whole, which is where I think we failed in this country.
Right, thank you. That's again a very important question. The WHO has thought of the 5x5 principles, 5 risk factors or risk determinants linked to 5 diseases: tobacco, alcohol, diet, physical activity, and air pollution are related to 5 diseases: cardiovascular disease, cancer, diabetes, chronic lung disease, and mental health. So clearly addressing all of these 5 or any of these 5 through policy measures, non-personal policy interventions, can make a big change. So coming to air pollution and health system, there are several ways health system can participate in mitigating the air pollution. One is doctors are a very powerful voice, and politicians, the media listens to them, especially the prominent doctors. So they need to advocate, and therefore we need education of cardiologists, pulmonologists, I mean, any of the high-tech doctors to talk to the policymakers. That's one. Second thing is health system itself has multiple reasons for increasing the air pollution as well as contributing to climate change. For example, the type of anesthetic gases that are used can increase some of the ozone levels, and can we change to right kind of the anesthetic gases is a question. The second thing is procurement. How can we procure things in a sustainable way? How do we manage our biomedical waste? How do we not waste food? Food waste is one of the major sources again of greenhouse gases. So these are some of the things that the health system can address if capacity is built in that area. And of course, telemedicine is an option because it reduces footfall to the hospitals and thereby reducing air pollution. So there are multiple direct and indirect ways of health system contributing to air pollution as well as mitigating it.
Thank you. And we've a few minutes left. I know Michaela wanted to come back on, particularly on the decision-making tool. Michaela, do you think your bandwidth is okay?
I'll try. Am I crackling now? Is that okay?
Okay at the moment.
Okay, so really it was about that shared decision. When you were talking about the decision-making tool, could you explain a little bit more about what that involved? Was it?
Okay.
Yeah, thank you.
So what we did was we developed this tool with case studies. So we put in around 3,000 case studies in the backend. Like it involved a variety of scenarios: 30-year-old female, 30-year-old male, 50-year-old female, 50-year-old male, with hypertension, with diabetes, without hypertension, with diabetes, with multimorbidities, and several other aspects. So given that it also has the AI feature and the machine learning, it actually builds on the 3,000 case studies that we have given. So, and it gives you a personalized management plan for each of the patient who comes to the hospital. So that's what we have done.
That's amazing. Wow. I was just, that's really, wow. I'm going to look more about it. It's really, I love it.
Yeah.
Thank you.
Thank you. And that's a really good way of winding up, because a number of the comments in the chat, Prabhakaran said the same sort of thing. Wow, what a presentation. It'll be on the C3 YouTube channel and available for people to re-see, or for those who weren't able to join. Thank you for the very positive messages. And can I invite everybody to our C3's next international seminar, which on November the 19th, same time, UK breakfast time, because this time we're part again of the London Global Cancer Week. And we will be hearing from Dr. Andrea Uy from Thailand, who's a bariatric surgery specializing in cancer and obesity. But really to say, Prabhakaran, that was such an inspirational talk. So much to learn, so much real envy of the size and the longevity of the studies, and the ability then to implement them, which is always such a challenge for researchers. So taking us the whole journey through research trials to real policy implementation. Thank you very much. Stay in touch as always. And thank you to all the people who joined us. Have a good day, or the rest of the day for those who coming towards the end of their day. And a special thank you to at least one person who must still be in her pajamas, because she's come from the USA. Thank you, everybody, very much. And most of all, Prabhakaran. Thank you, and bye-bye.
Thank you.